Hello, and welcome to the Bon Secours Richmond Community Education Program on Neuroscience. I'm Pat Lane, and I'm the Neuroscience Coordinator for Bon Secours Richmond. Last week, we talked about the risk factors of stroke and shared with you the unfortunate statistic that every 40 seconds, someone has a stroke. Today, our community education on neuroscience awareness will focus on the signs and symptoms of stroke. We will discuss the different types of stroke. We will share with you our systems of care at Bon Secours and also our treatment approaches. If there are any questions you would like answered, or if you want more information after tonight's show, please make sure you contact Bon Secours' number at 804-359-WELL or 9355. Or check out our website at www.bonsecours.com. Or you can contact me, Patricia_Lane at bc.org. And this information will be at the bottom of your TV screen throughout the show. This evening, I am pleased to host Dr. Herman Getulio, Dr. Robert Beskin, and Cam Crittenden. All our members are from our neuroscience team. Our topic again this evening is time is brain. What are the treatment approaches for stroke? I am happy to introduce our first panelist, Dr. Herman Getulio. Dr. Getulio is a neurologist and is the medical director for St. Francis Medical Center. He is board certified in neurology, and his practice office is Neurology Center of Virginia, located in Midlothian. Dr. Getulio received his doctorate in the Philippines and did his internship and residency right here in the city of Richmond at VCU. He is very well published and well versed. Thanks, Dr. Getulio, for taking time to be with us today. Our next guest is Dr. Robert Beskin. Dr. Beskin's specialty is interventional radiology. He is affiliated with Bon Secours Virginia facilities, and his practice is with Commonwealth Radiology. Dr. Beskin received his medical degree from Tulane University in New Orleans, and he specialized in neuroradiology and did his fellowship at the University of Virginia. Thank you, Dr. Beskin, for being here with us today. We look forward to you sharing your experiences with us. Our third panel member is Cam Crittenden. Cam is Emergency Medical Services Coordinator for Bon Secours Richmond. Cam is a registered nurse and a graduate of VCU. Cam is certified as a flight nurse, a trauma nurse, pediatric advanced life support, and advanced cardiac life support. Cam has an excellent working relationship with EMS and throughout Richmond and will help us understand the EMS system throughout Richmond. Welcome, Cam, and thanks for being here today. So callers, we will take your questions between 6:30 and 6:45, and the number to call is 804-915-5202, and we look forward to hearing from you. So Cam, I'm going to start the discussion with you and talk a little bit about your background and your career in reference to gravitating to emergency services and your certifications. Can you share with us what made you go into that specialty?
You know, I was a late bloomer. I went to nursing school at 35 and was doing a rotation at VCU in the emergency room and knew right away that's exactly what I wanted to do. I became a volunteer with the local rescue squad, and I rode an ambulance prior to becoming a nurse and for my first couple of years being a nurse. I've been in the emergency room since I started in 1999. Managed to be lucky enough to spend 4 years flying medevac at a local helicopter company, so I've got a great working relationship with EMS and really love it.
Great. I'm sure that adrenaline rush comes as well with those things. I think that's great. So last week we talked about a few of the risk factors of stroke: smoking, diabetes, hypertension, and sleep apnea. And we'll talk a little bit more today about what with the physician panelists. But can you start the dialogue of systems care in that sharing with the community, if somebody were to call 911, of any type of medical emergency, what would they expect to get back on that call?
Immediate response. We have a very sophisticated EMS system in Central Virginia. We have integrated agencies with the hospitals. We have very lucky, for the most part, to have ALS ambulances cover all of our areas. We have backup agreements in place. EMS is our first point of medical contact with our patients. They're integrated into our hospitals. If you call 911, you're going to get rapid response by a well-trained ambulance crew. They'll take care of you.
Great. So we use the acronym to teach the community FAST for recognizing the signs and symptoms of stroke. You know, F is for facial droop, A, arm is for weakness, S is for slurred speech, or sometimes you can't understand what you're saying, and T stands for time last known well. And so this is a very brief description of what we want people to know. Dr. Getulio, can you elaborate on these signs and symptoms and other signs and symptoms you might see for having a stroke?
So the FAST acronym, I mean, it's one of those acronyms that is essential and quick to recall. But really, when it comes to symptoms of stroke, it's any neurological symptom that you have that is new and you've never had before. So whether it's an issue with your thought process, your speech, your inability to feel something, your inability to move an arm or a limb, wobbliness with walking, anything that is new and you have not experienced before, instead of you having to decipher what that is, my recommendation always to my patients is that you go call 911 and have the emergency room physicians and the neurologists then determine for you whether it's a symptom of a stroke or not.
Okay. And so I've heard, and I do know, that one of the things that we use right away to screen is what we call the NIHSS. So can you talk about what the NIHSS is and how we use that scale?
So the NIH stroke scaling was basically formulated so that there be some uniformity in assessments of stroke wherever you go in terms of an emergency room setting or even just a neurologist setting in a clinic. So what it really tests is all the aspects of your neurological function, from your ability to speak, to answer questions properly, to move an arm, a leg, to be able to read off of a picture, describe a scene off of a picture. Then from there, each of those are assigned points, and from those points, they're totaled at the end, and then one can determine whether you fall within a criteria of treatment and also determine whether you have a large vessel stroke that would require more detailed testing than just a smaller event. But it's really used to provide a standardization of assessment, and it's also used to assess improvement while you are in the hospital based on your initial NIH stroke scale and then your discharge stroke scale. And it also gives your neurologist the opportunity to then do another scaling when you visit the neurologist in clinic after your discharge. Okay. So it is a form of uniform assessment.
Okay, and so I know we use that in the hospital and the doctors use it. Cam, do we also use that out for EMS, or do they use another type of scale?
They use a Cincinnati scale, which mimics the FAST scale. They have trained with the hospitals and working together so that we use similar assessment techniques so that we're speaking the same language, so that if EMS assesses you in the field and they say, this is what I found, we do a similar assessment in the hospital, and as Dr. Getulio just said, we can gauge whether they're getting worse or getting better. So we do have a unified assessment system that way.
Great. And I know in the FAST acronym we emphasize T for last time known well, and that really is something that is very crucial. We want to make sure that the EMS personnel really try to find out that, because depending on the time that person was last known well for their stroke, we may be able to treat that stroke. So I'm going to have Dr. Getulio also briefly talk about the two types of stroke and why we want to know that, and the stroke and what someone might have.
So just to emphasize Pat's point, that time is key. That's why, it is essential for when you develop any of these neurological changes to call 911, because opportunity for treatment is based on the time that you actually present to the emergency room. With regards to the types of stroke, there's two main types of stroke. One that they call ischemic strokes and hemorrhagic strokes. Majority of strokes, about 2/3, are ischemic strokes, and those are just stroke events due to loss of blood supply, and then the area of your brain, because of the lack of blood supply, does not function or dies. Hemorrhagic stroke are basically blood vessels that burst and cause blood to develop in your brain and form a compressing phenomenon. But majority of strokes are ischemic strokes. And so those are the ones that when you end up in the emergency room, that one looks for whether you've had either the ischemic type or the hemorrhagic type.
So Dr. Getulio, how can we tell, what diagnostic do we use to know if you have a ischemic stroke or you have a hemorrhagic stroke?
So the standard imaging that's done in all emergency rooms is a head CT scan that immediately determines whether the cause of the stroke is due to a hemorrhage or a bleed, or it is not.
Okay. So now this comes right down your alley, Dr. Beskin, because you're in radiology. So I want to ask you, first of all, thanks again for being with us. There's several questions I have for you. So Dr. Getulio just shared with us that we can tell the difference of a stroke by doing this radiology procedure, a CT scan. Can you share a little bit more with us about the difference in the picture of what you might see with ischemic and what you might see in hemorrhagic? And can you tell the difference, or what are you looking for when you look at that?
Okay. Well, a CT uses x-rays, the same as if you get a chest x-ray or a bone x-ray, but because it's done with the use of a computer and a lot of detectors, the sensitivity for small differences in density is much greater. So when we look at the head, in particular with the CT scan, if there's blood when it is outside of the blood vessels and starts to clot becomes more dense than the surrounding tissue. So when we do the CT scan, we see increased density in the brain or around the brain, and we know that's blood. On the other hand, when somebody has an ischemic stroke, we see the opposite. We see fluid, water, leaking into that area of the brain that's damaged or infarcted, and that has decreased density, and that's generally what we see on the CT.
Okay. Dr. Beskin, are there any other diagnostic tests that you may request for the treatment of a stroke? And if so, what might that be besides just a regular CT?
Well, usually after the neurologist has evaluated the patient, and in consultation, if there is thought that there may be additional treatment that might take place with intraarterial treatment, we'll get a CTA. And a CTA stands for CT arteriogram, and it is a way to look directly at the blood vessels and try and find if there are any blood vessels that are actually still blocked off. And so that involves injecting the dye into the arm. You don't have to inject it into the arteries. It injects through an IV in the arm, a rapid bolus injection of contrast, and then we do a rapid scan of the head and neck, and we can look at all of the blood vessels in a really quick order of only a few minutes and determine if there are any blockages.
That's good. And I was going to ask you, you started at the end, which was really good, to share with the community. Some people may have never heard what an interventional radiologist does. So if you can just share that. And then you have another specialty in neuro. So if you want to talk a little bit about your history and background and what's the difference between a radiologist and somebody who does interventions, that would be good.
Well, intervention procedures have evolved to involve a lot of imaging-related procedures. The interventions work best a lot of times when you can actually see the things you're doing. So radiology in general over the years has become more and more involved with using catheters, needles, and other devices with imaging using primarily X-rays, fluoroscopy, to see where the devices are and where the pathology, the abnormality is, to access it. So interventional radiology is divided amongst procedures such as biopsying tumors in the body with needles, placing sometimes devices with minor surgery, but as it relates to stroke, it's primarily related to intravascular treatment, which if there is an actual stroke and we get the CTA and there's a blood clot, of going up into the blood vessel and either putting strong medicine that dissolves the blood clot or going up with a device to actually remove the clot from inside the blood vessels. That is under generally neurointerventional procedure, which is done by radiology, but also there are also people in neurology and neurosurgery that are also involved in this type of procedure.
Okay, so we just talked about some of the things an interventional radiologist does, and I did see the community. There is a good DVD that I thought would help to share a little bit about looking at what those arteries and the vessels were to give you a visual of the insight. So we'll cut to this DVD right now to be able to show you, and this is from AstraZeneca and also talks about the arteries. It's called the Artery Explorer.
Mission is to find a killer, one whose work can start while its victims are still in early adulthood, and the diseases it causes are the leading cause of illness and death in the United States. This killer is atherosclerosis. Some people may not have heard of atherosclerosis, but the risk factors that contribute to it may be familiar and include obesity, elevated blood pressure, diabetes, a family history of heart disease, high cholesterol, or simply growing older. All affect our arteries. Some things we can change, like stopping smoking or changing what we eat, while others, like our family history or our age, we can't. But we can all take steps to reduce our risk of suffering a heart attack or a stroke by improving the health of our arteries. To understand how we can improve the health of our arteries, we will need to take a closer look. So sit back, relax, and enjoy. We are now in an artery, traveling with red blood cells that carry oxygen to major organs throughout the body. And this is cholesterol. You may have heard about cholesterol, but did you know there are different types? The most important are LDL cholesterol, known as the bad cholesterol, because it can lead to clogged arteries, and HDL cholesterol, called good cholesterol, because it is believed to help remove cholesterol from the body. Generally, our aim is to keep good cholesterol levels high and bad cholesterol levels low. When there is too much bad cholesterol in the blood, this can cause serious problems. When there is damage to the lining of the artery caused by, for example, high blood pressure, LDL cholesterol is more likely to enter the wall of the artery. When LDL or bad cholesterol enters the damaged wall of the artery, it changes and can lead to inflammation. Over time, inflammation in the artery wall creates something known as a plaque. Plaques can start forming at an early age, and over time, this can lead to clogging of the arteries. This can happen in a number of different sites around the body and can get progressively worse over time. This chronic process, known as atherosclerosis, can become life-threatening depending on whether the plaque is stable or unstable. A stable plaque can continue to grow, slowly reducing blood flow over time by hardening and narrowing the artery, but does not necessarily completely block the flow of blood. But sometimes even a small plaque can become unstable and rupture, exposing its contents. This is much more dangerous than a stable plaque, because a clot can quickly form, completely blocking the flow of blood. As stable plaques form and cause narrowing and hardening of the arteries in the legs, the blood flow is restricted, sometimes making it painful to walk. Elsewhere in the body, the effects of plaque rupture can be immediate. A blockage in arteries supplying blood to the heart can cause a heart attack. A blockage in arteries supplying blood to the brain can cause a stroke. So what can we do to help maintain healthy arteries? Addressing our risk factors will benefit our general health and the health of our arteries. We can stop smoking, change our diet, exercise more. With the help of your doctor, you can manage other conditions that may affect your arteries. Of course, some things, like your age or your family medical history, you can't change. If you were concerned about atherosclerosis and the health of your arteries, talk to your doctor about having your blood pressure, blood sugar, and levels of good and bad cholesterol checked. If you have seen your doctor and are being treated, continue to follow your doctor's instructions. Us Against Athero, brought to you by AstraZeneca, is a movement to spread national awareness of atherosclerosis and empower people with the knowledge.
Okay. This short clip also emphasized the risk factors of stroke, which we did talk about that last year, but it really clearly looked at it last week, but really talked about the LDL, so we want to talk about that. That LDL, I always remember, as being something that is lethal, so you want to keep it low. The HDL, we want to keep that high because we want it to be healthy. So callers, we're going to ask for you to call in. You got a couple of minutes before you do that. But the number again at 6:30, you can call in at 804-915-5202. So Cam, I'm going to go back to you. EMS really does start our golden hour when we talk about our system of care for stroke, and community recognize that somebody is having a stroke. So when EMS now arrives at the scene, you helped us to talk about dispatch and how they go, but once they get there, what happens when they arrive to the scene? What can the patient or family expect?
You're going to expect a couple things. First of all, they're going to be moving very quickly. I mean, they've gotten a heads up from dispatch what the symptoms are, and in their mind they're thinking this is possibly a stroke. So time is of the essence. They're going to be moving very quickly. They're going to do probably a lot of things at once. They're going to do a quick head-to-toe assessment of the patient and get an idea of the range of symptoms. They'll do the Cincinnati scale. They'll also check a blood sugar, because sometimes low blood sugar, low glucose can mimic the signs and symptoms of a stroke. So they'll check your blood sugar, and if it's low, they'll treat that. If they've ruled out blood sugar, you're going to get an IV. You're probably going to get an EKG also. But all this is happening very quickly. At the same time, they're getting you on a stretcher. One of them might pick up a phone. They're probably calling the ER to say, hey, we think we have a stroke here, which mobilizes our stroke team in the emergency department. We coordinate that very well. They're going to talk to the family a lot. A lot of times, stroke patients aren't able to give a history. They can't speak. Their mental status is off. They're scared. They don't know what time this happened, but family members have witnessed it. So they're going to be interviewing the family members to find out sort of the history, but really what time, the last time you saw them normal, because that time is very important for the treatment that we're going to initiate in the emergency department with the neurologist. So a lot of stuff happening at once, but basically rapid transport is key. They're going to get them in the back of the ambulance and on their way to the hospital as soon as possible. Good.
So I heard you also say the EMS will call the hospital. That's good. So that really helps with us being able to get that time going in a team in place. Now, how does EMS know where to take the patient, or how is that done? Can you speak to that a little bit?
We have the hospitals, the medical control physicians, the EMS agency representatives. We meet on a regular basis, and we have developed, along with the Virginia Stroke System Task Force, an integrated stroke response plan. Our EMS providers are educated. They know the capabilities of the hospitals that are in our area. They know where the closest appropriate facility is, and they're going to get that patient to the right facility for the right treatment in the right amount of time.
Okay. So I'm going to emphasize, and I think we all will throughout this talk to our community, the EMS arrives on the scene. We know that the patient had their stroke-like symptoms within the last 2 hours, and there may be a possibility of treatment. So we're all going to be moving in sync. Dr. Getulio, what happens with the neurologist? When are you notified Because a lot of times you may not be in the hospital, and how does that work for you?
So the way we've set up our system at St. Francis or Bon Secours Richmond altogether is that once EMS informs the emergency room that there is a potential stroke candidate, there is actually a code stroke that is activated, and all the physicians, ancillary services that are involved in stroke care are paged or are warned that there is this patient that is coming to the emergency room. So that's the first time that we hear about that potential patient. And then the next thing is we then call the emergency room and discuss the initial assessment of the emergency room physician to confirm that indeed this is a patient that may be undergoing a stroke, and also get an initial NIH stroke scaling that we talked about earlier. So the way we've set up the protocol in our system is that the neurologist is involved throughout the process, even before the patient reaches the emergency room, especially if EMS already forewarns that the patient is a stroke patient.
Okay. So the CT comes back negative. NIH stroke scale's been done. The NIH is between 4 and 10. What treatment can be done if it's a negative CT?
Mm-hmm. So that's why, as the FAST acronym, we mentioned it earlier, the T is time. Time is of the essence, because if you are within the 3-hour window from your initial onset of symptom of your stroke, and then you fall with the initial NIH stroke scaling is done, and you fall above 4, then you are going to be eligible for treatment. And the treatment for that is the clot busting medication, what we call TPA. And so that's why it's essential for you to call EMS, and for the ER to be informed that there is a potential stroke, and then for that initial assessment to be done. If the NIH stroke scaling is more than 10, we actually go above and beyond the regular protocol and do what my colleague here mentioned about the CT arteriogram. In order to, because when the NIH stroke scaling is more than 10, it clues the neurologist that the event could be due to a large vessel occlusion, and usually that's due to a clot. And so if the NIH stroke scale is more than 10, then we go ahead and do a CT angiogram, and that is entrenched in our stroke protocol in order to confirm if a clot is present or not, and because then that will lead us to not only do TPA as a treatment, initial treatment, but then allow us to be able to transfer the patient to our sister hospital, which is St. Mary's, that has the capability of doing interventional procedure that my colleague does.
Okay. So Dr. Beskin, when do you actually get notified for that or to be involved? And tell me the types of treatments that you might be able to do if it's above 10, and what do you need to see on that CTA to get that done?
Well, generally we are involved sometimes with knowing about some of the stroke cases that are coming in ahead of time, but usually, like he said, we don't get involved until it gets above 10, and that is primarily because once we go to a level where we're doing something invasive in the blood vessels, also the risks go significantly up of causing some potential harm, and primarily the big thing that happens that we try to prevent is bleeding associated with the TPA or these mechanical devices, getting them up into the head, or additional stroke, particles or thrombus breaking off and going up in the head. So we do not like to be involved unless it is at least 10 because of the risk benefit related to the treatment. And when we have the CTA, the neurologist is always involved, and if the patient is not improving, and still has a significant deficit over a stroke scale of 10. And there is a large thrombus in one of the vessels that looks amenable to treatment with endovascular, going up into the blood vessel and taking it out, then we will consider doing the procedure. And there are other factors involved, which sometimes people are quite elderly and they have very tortuous, very windy blood vessels, or have other dense plaques and narrowings that might make it too risky to do the procedure. The other thing that we're looking for when we do the CTA, and sometimes we do another test we haven't talked about, which is perfusion, which we can do at the same time as the CTA to see the blood flow to the brain. If it looks like a large area of the brain has lost blood supply to the point where it is starting to die, or we feel it's on the verge of being infarcted, then at that point there probably is no point in doing additional treatment. A lot of that depends on what we call collaterals. Collaterals can be thought of as detours, just like a road. If you have a single road going to your house that's blocked, you can't get there. But if you have a back road to get to there, there's multiple ways of getting there. Then the same thing with collaterals and blood vessels. There are lots of ways for the blood to get around. As long as there are collaterals, and everybody is different in how many collaterals they have and how well they work. But if there are a significant number of collaterals, the brain can stay alive for a significant amount of time, maybe even sometimes hours. There's a significant amount of brain that hasn't really been affected by the blood clot, that if we can get it out, we can save that area of the brain. So all of these factors are taken into consideration and in consultation to decide whether we are going to go ahead and go forward with the treatment. Also, very important is to discuss it with the family, the options, and let them participate, because there are no absolute answers. Some of the things we do, if we go up and put intra-arterial TPA in, it's an off-label use of TPA. The devices that we use, which we haven't talked about, these mechanical devices to pull clots out, they're mostly FDA approved, but they're not well defined in trials. So there are a lot of risks and things that have to be discussed, but there's also a lot of great opportunity because stroke is so devastating that if it's a good case, that we can have miraculous sometimes results in improving people's outcomes.
Mm-hmm. And you said, and I forgot to mention, which I should have said probably in the opening, that stroke actually is the leading cause of disability. And as people are getting older, we're aging. That's like fine wine even more now as I get older. But you live longer, and so you want to make sure that you have a quality of life. So a lot of times people would like for you to treat with that. So you talked about intra-arterial. What are the other two types of endovascular procedures you can do for stroke, the mechanical devices that you talked about there too?
Well, initially there were two FDA-approved devices. One was called Mercy, which was a sort of a coil of wires that would go up and entangle the clot and then would mechanically be pulled out. And the next one that came along was called Penumbra, which was actually a suction device that used a small catheter would go up into the clot, and then it had another smaller wire inside that would break off little pieces as those little pieces would be sucked out and removed. Also, sometimes just putting a catheter up there, and just if you can get a big enough catheter up there, you could just do a suction embolectomy with the catheter, is just actually remove the clot with a catheter if you can get a bigger one up there. Lately, two new devices have come on available that are FDA approved, which are they're using stents that were initially developed for treating narrowings in the blood vessels. The first one was used, that particular stent, to grab a hold of the clot because it would open up the vessel and then grab the clot, and you could pull it out in the same way that the Mercy device. And then now there's a newest stent retriever that is out, is called the Trevo, which was specifically designed for this and is smaller. The improvement of these newer devices, these stent retrievers, is that they're much smaller, they're much more flexible. So we have a much better chance of getting it up to where we need to in the thrombus. That is a lot of time, people that have stroke have a lot of associated atherosclerotic disease like I already mentioned. So a lot of times the challenge is we just can't get there because of the amount of blockage from narrowings and tortuosity of the vessels. So as the technology improves, we have a better and better chance of being able to actually get there to remove the thrombus.
And that's kind of why we wanted to show that DVD today, to show you how the arteries are and where the plaque can build and the forming of that. Callers, we will take your call for the next few minutes. If you would like to call in, the number is 804-915-5202. So I'm going to now also talk about one of the things that we ask in that assessment that I think are both very important for both of you in the assessment is what medications that patient is on before you can decide whether you're going to do treatment. So I don't know if you want to talk about that, Dr. Getulio, with our AFib patients and what we're looking for with our specific lab tests before we can give that clot buster.
Yeah, so in order for you to be eligible for treatment for TPA, there are inclusion and exclusion criteria. And the inclusion and exclusion criteria really look for risk of bleeding, because the medication in itself, the major side effects or adverse effect of that is bleeding. So you look for if patients had previous surgeries, previous interventions, use of medication that can lead to increased bleeding risk. So people who are on warfarin and the newer medications that are used for AFib, Prodexa, is that Soleto? Exaltra. So those you need to be able to get those information in order to then include or exclude the patient from treatment based on the risk of bleeding from giving the medication. So we test for kidney functions, bleeding times, and etc. in order to make sure that you do get the benefit and not the adverse effect of the TPA treatment.
And the other thing, Cam had said when EMS comes, one of the things that they look at is doing a blood sugar. That's very important for us for diabetes. And the other thing that's really important is their blood pressure. Because if your blood pressure is higher than 185/110, then we have to bring that blood pressure down.
So from our standpoint, in terms of your eligibility for treatment with a clot busting medication, hypertension is one of the exclusions, but it's not a contraindication, because when you come into the emergency room and if your blood pressure is beyond what Pat has mentioned, it's not actually that we then stop there. We attempt treatment with medication to lower it down. And if the medication allows it to be below the cutoff, then you are still eligible. So it doesn't mean automatically that if your blood pressure was extremely elevated when you came in that you will be excluded. We actually afford treatment of 1 or 2 IV labetalol and see if then we can actually improve your blood pressure and then make you eligible for the treatment.
Okay. Dr. Beskin, if we were to get a treatment interventional, who's on your team? What members? Are you doing this by yourself? Is the patient awake the whole time? What should they expect in your area?
We have 4 interventional radiologists that are covering the call, with the second part.
And who works with you, like with that patient? Who would just be working with you on that with that patient?
Well, we have a team of radiology nurses and technologists, and they would be involved in communicating with the emergency nurses involved, and the patient would be transferred down to the angiography suite in the radiology department. There we have a very sophisticated fluoroscopy unit that can look in 2 planes at the same time, which makes things faster when we're doing arteriograms and looking for where the problem is and if we have to treat it. And they would be brought down to that area, and they'd have an arteriogram. And if anybody has had any family members with cardiac catheterizations or any type of arteriograms, they're all very similar. They're done with similar fluoroscopy equipment, and that's what we use for the procedure to try and remove the clot. And it involves an actual arteriogram to see what the anatomy is again and see if the clot is still there, and then to use the various devices to remove the clot. One other thing is that if somebody were to come in who was anticoagulated, particularly people that are in atrial fibrillation, and they were anticoagulated to the point where they were not a candidate for the TPA, they could still be a candidate for the mechanical devices to remove the clot.
And what we didn't talk about was how many hours we can go out for your procedure. So if you want to speak to that, I know for the clot buster.
So that for the TPA, it's within a 3-hour window. But then once we have, as I've mentioned before, that the NIH stroke scale is more than 10, we do the CT arteriogram, we actually confirm that there is a clot, then the treatment for that is extended to within the 8-hour window. Is that right?
Yes. And a lot of that depends on what the imaging shows. We touched on a little earlier about the infarction. If there is already a significant volume of brain that has died, then reperfusing, pulling out the clot, even though you can have the picture look good and get rid of the clot, can actually do more harm by increasing the chance of bleeding into that area that is infarcted, and also by increasing the perfusion. Sometimes you can have a lot of swelling, the brain swells and can result in a lot of other problems. So if the brain area is determined to already have infarcted and it's of significant size, then they won't be a candidate for intraarterial. But if even several hours out, up to 8 hours, if these collaterals we talked about earlier, these detours are well formed, you can sometimes be out quite a few hours. The CT scan or the perfusion scan, or sometimes we even do an MRI, show that the brain is still intact. We can do the procedure several hours and sometimes out 8 hours, and with rare occasions even out into double-digit hours, depending what's at stake. If it's the posterior circulation, we tend to be a little more aggressive in those situations. But I don't want to underemphasize the fact that it's always the sooner you get in, the better. Nobody should wait. No matter what treatment that you're having relative to your stroke, and to prevent you from having additional problems with that, even if they're transient, minor, always come immediately, because time is very important.
And I think Cam has said that a lot too, and expressed it with EMS. What about the family, Cam? I guess if somebody's coming to the hospital, does EMS help them to navigate? Cause
usually they'll, the best case scenario is to bring a family member with them so that they can continue to get a history, that they're there and available to the physicians when they get to the emergency department. That's usually the best source of history if it's a severe stroke. So we do want to include the family member. We'll bring them. If for some reason the family member can't, be prepared to give your phone number or contact information, at least the person last saw the patient well, because we will be calling them to get more information. I mean, it's definitely the more input we have, the better it is for the patient.
And I know also there are different types of squads. I meant to touch on that in the beginning as well. Can you talk about that? I know there's paramedics, there are volunteers. If you can tell us a little bit.
There's two different. There's advanced life support units, which are staffed with paramedics, and then there's BLS units, which are basic life support. We do have ALS coverage in the Metro Richmond area, whether it's on that BLS unit or they rendezvous with an ALS provider. But the big key is getting them to the hospital as quickly as possible. All BLS providers can do a blood sugar check and can treat for low blood sugar, so they can rule that out. A BLS provider won't do an IV, but they can call or report, they can pre-alert the emergency department and get the patient there as quick as possible. So that's the best, shortest amount of time to the hospital. So they're all trained in doing that, whether it's an ALS unit or a BLS unit.
Okay. And also, I know we've just opened our Watkins Center, and if you're close, I mean, we all said we really don't want anybody driving, and you really should call 911. But depending on where you are, if you're right there at the urgent center, which is at Watkins, we can start it, and we can do what we call a drip and ship. and the patient can be able to start that IV, get that treatment going. Neurology can come in and work with ED, and then you can be flown, or they advanced life support can come and take you somewhere else as well.
Yeah, I think what people need to understand is that there is structure to stroke care, especially emergency stroke care, here in Virginia, especially within the Bon Secours system. So that when you go to the emergency room, it's not going to be that people do different things. No, there is actually a standardization so that the workup those are the same workup that each and every stroke patient obtains. Criteria are done, and so the treatment protocols are in place, so there's no deviation from the standard of care.
And once that patient has been treated, or if you come outside of that window of 8 hours and you're beyond what we call the acute phase, we still are a primary stroke care center. All of Bon Secours facilities are. And so you can expect a system of care with that as well. Some of the things that we'll make sure that we do right away is what we call getting a swallow screen, because the one thing we don't want you to do if you've had a stroke, we do not want you to have your pills, your medicine, or eat any food without having you do some type of swallow study, because we don't want you to be at risk for aspiration pneumonia. So that will be one thing that will be done right away. And then we'll make sure that we give you an aspirin. We want to start you on some type of anticoag right away so that we can make sure we keep things moving. As you saw in that video, we want to make sure that you have your blood thin a little bit so it can go through and get the oxygen and everything you need to the brain. And then we also will assess, depending on where it is in the brain, you may need to have rehab services. And that's important as well. And we want to look at why you're there. What brought you in for having that stroke? And so we'll do all kinds of assessment and an echocardiogram and Doppler tests to make sure things are moving and see what was going on with that.
Yeah, to add on to what Pat is saying is that once it's been established you've had a stroke, whether it's acute, that you've received treatment, or whether you're past the window, then the next step really is the reason you need to be in the hospital is because we do what we call a stroke risk stratification workup. We need to find out why you had the stroke. And so we do all the necessary workup, from looking at your heart. Is there a clot lodged there? Do you have a hole, what we call a patent foramen ovale, that increases your risk? Do you have issues with diabetes? Is your lipids normal, or you're actually having issues with that medications need to be adjusted or started? Do you have issues with vitamin deficiencies, thyroid issues, inflammatory arthritic issues that again predispose you to develop atherosclerosis and increase your stroke risk? Because we want to make sure that before you leave that hospital, that all the possible causes and reasons of you having had the stroke is addressed. And so that's why it's essential for you to be in the hospital, even if your symptoms is beyond the 3 hours. I think one of the things we didn't touch on is that what if your symptoms resolved as EMS came by, or when you were in the emergency room? Then you're not anymore considered as somebody having had the stroke, but somebody having what we call a transient ischemic attack, or a TIA. Is that going to be any different? Actually, for the cases of TIA, it's like a warning, and you still need to go to the emergency room because you still need to be emergently evaluated as to why did you have a warning for a potential stroke. There is, over at St. Francis, we actually participate in a point study trial for patients with transient ischemic attack, and we do what we call an ABCD criteria assessment, wherein we look at your age. If you're beyond 60 or less than 60 years old, it adds onto the risk. Your blood pressure that you presented with, if you were hypertensive, there's a score for that, or if you were not. If your symptoms included weakness, speech changes, how long was the symptom, were you a diabetic? And then based on that, we actually formulate a score, and we can determine what is your 90-day stroke risk, whether you're mild, moderate, or severe risk, or a serious risk for future stroke. Because then if you are, then it warrants for you to be in the hospital, again, to have a stroke risk stratification workup as to why did you have that warning for a stroke. So when you call 911, it's not just for symptoms that persist, but even for symptoms that it occurred all of a sudden and even improved.
Right. So I would say, again, don't be afraid if your symptoms resolve and EMS comes, you need to still tell them exactly what was going on so you can be able to have those symptoms taken care of.
And they will encourage you. They will encourage you. They will tell you you still need to come to the hospital. Even though they're resolved, you still need to have your workup.
Good. Now we talked a little bit about our risk factors, and you saw them on the DVD. We talked about it last week, but again, I'm going to stress hypertension is a very big risk factor, and diabetes for having a stroke. This weekend, on the 20th, is the American Heart Association's Start Walk. So I'm sure a lot of people have heard about that, and there'll be a lot of information and screenings out there, and I think it's at Innsbruck, and there are going to be really different walks all around the city for you to be able to see that. And we also are having some information every Saturday at our Watkins Center, so that's on the other side if you want to hear some information about that. The Virginia Department of Health also is working with us for hypertension, and you may hear out in the community something called A Million Hearts. And while we're talking about neuroscience, it has some of the same risk factors. So A would be making sure you get that aspirin on board. B is looking at what your blood pressure is, and the C, so it's called the ABCs, is looking at your cholesterol. It's a fine line with the syncopes and TIAs and strokes. They all run some of the same things that we need to look for and to be able to treat. Now, Dr. Beskin, I saw you have something here about aneurysms we haven't talked about. Would you like to mention anything about how you care for aneurysms, and do we do that at St. Mary's? Or what we would do if somebody came in with an aneurysm, we would refer them to somewhere else, or what they need to look for if they see those signs?
Well, one of the types of strokes that was talked about earlier was hemorrhagic strokes, and one of them is into the parenchyma of the brain, but the other one that's relatively common is a subarachnoid hemorrhage. And subarachnoid hemorrhage means it's bled into the spaces that have spinal fluid, which is just water around the brain. And that has two effects. One is very irritating to have blood in these areas, and also it increases the pressure in the head. And it's a very serious event, and people that have these blood vessels rupture from aneurysms, and aneurysms are just little weak spots in the blood vessels, sort of like a weak spot if you imagine on a garden hose that starts to get a blister or a bubble, and then it ruptures, and then the blood bleeds into the head, and it usually stops, but sometimes it bleeds to the point where the patient dies. And it's very serious because somewhere around 50% or so will either die immediately or in the following month from this when it happens. So the two things we'd like to do is, one, if somebody comes in, is to get immediate treatment for that. And then also, if there's a strong family history or something, it's ideal to find it before these aneurysms even rupture, because they can be treated. The traditional treatment is neurosurgical treatment with small metal clips that are put inside through a craniotomy into the head, or put on the blood vessels to fix the little weak area in the blood vessel. And that has been around for decades by neurosurgeons, and that's a very proven treatment. The newer treatment is endovascular treatment, where you go up through these same small little catheters are put up into the blood vessels, into the head, and usually what is used now are small platinum coils, which are very small and very soft and can be formed inside the aneurysm until it is blocked off. There are some glue-like substances that are also starting to be used for treating the aneurysms, and also stents that will actually reconstruct the blood vessel and isolate the weak area, sort of replace it with a strut across the area where the weakness was. We do offer we offer the clipping at St. Mary's, and we do have the opportunity to do the coiling also at St. Mary's, and other facilities are available.
Okay. And I did, again, want to emphasize that all of our centers are primary stroke care centers, so we do have a system of care in place, and if there's somewhere else that we need to go, we make sure we have the resources available to do that. As part of our systems of care, we also look at performance improvement and quality, and we want to make sure that, I'm very proud to say at all of our Bonsicle facilities, we have received special awards from the American Heart Association for looking at our systems of care. And one of the things that we do is always follow up with all of our providers about what went well, what time we did things, and how we can better our processes. So we do that also with our EMS providers to make sure they know that they did a great job of bringing somebody in, and then this is the story and how you helped this patient to be able to go on and help their family. So we're almost in our last few minutes here, and I wanted to give an opportunity to everybody. We'll start with you, Cam, about if you have any lessons to say.
I do. I actually have two. We've talked a lot about the wonderful treatments that are available, but as a nurse, my preference would be that you don't have a stroke. So anything you can do to prevent it. So if you can modify any of your risk factors, live a healthier life, look at your lifestyle, look at your cholesterol, look at your blood pressure, take your medication. Don't have a stroke is the best option. Second, if you do have a stroke, they can be devastating. But they don't have to be. Call 911. I've heard so many times, I didn't feel well, so I went to bed. Or my wife said he wasn't right, but we didn't think anything of it. Call 911. We're here to help you, but the team can't get activated if you don't call us. So that's the most important thing.
Okay, Dr. Beskin.
I don't have a specific advice, but I do have a question that I think we may have left out. What about the people that last week or a couple weeks ago or even a month or two ago, they had very clear symptoms that we've talked about tonight, but it's now been weeks or days or weeks since that happened? What should they do now if they feel they've had one of these events but it went away?
Yeah, so if you did have those events that didn't occur acutely, as you mentioned, it actually occurred quite some time, you have to see a neurologist, because then a workup again needs to be done in terms of what I've mentioned, which is a stroke risk workup, and see why you had the event. Are there other risk factors that are still not addressed? That's actually, interestingly, when we find that you may have had an aneurysm as the cause of your symptom based on the workup that's done, or a hole in your heart, or issues still with cholesterol. But you need to make sure that you mention that to your primary care doctor, so that your primary care doctor can then send you to the neurologist for further evaluation. From my end, the only thing, as I've mentioned before, don't decipher the symptom for yourself. If there's anything new that you experience, have a professional actually decipher it for you, and that's really calling 911 and going to the emergency room. It's a win-win situation for you.
Okay. And I think you're going to hear the same thing over from our team. Is one, know your baseline. Know your body. If something just doesn't feel right, then it probably isn't right. And so you want to go and get some help and get it checked out, or, and just make sure that somebody else knows what's going on. But 911 is there for you. It's the emergency medical system. Cam has talked to us about dispatch today and what you expect to get with that. So we want to make sure that you all are aware of the signs and symptoms of stroke. We used FAST. Facial droop, you're looking at your arm may drift, and your speech may be slurred. And then T is time last known well. So until next week, have a safe Neuro Week. Next week we'll be talking about seizures. So we look forward to you all calling in and being with us next week. Thank you.